Most people think insulin therapy is one size fits all. You get diagnosed, you get a shot, done. But here's what almost nobody tells you. There are fundamentally different insulin strategies, and picking the wrong one can leave your blood sugar swinging for years while you assume that's just how diabetes feels. In the next few minutes, we're breaking down the real difference between simple and intensive insulin regimens, the exact thresholds doctors use to decide between them, and the biological reason one approach mimics your body while the other fights against it. Let's start with what your pancreas actually does when it's working normally, because every insulin regimen is really just an attempt to copy this. A non-diabetic body maintains a constant, low-level trickle of insulin around the clock. This baseline, called basal insulin, exists to stop the body from converting muscle and organ protein into sugar, a process called gluconeogenesis. On top of that steady trickle, the pancreas releases a much larger burst of insulin, called a bolus, whenever food comes in, and that burst lasts for roughly 5 hours after a meal. Basal keeps you stable while fasting. Bolus handles the flood of glucose from eating. Everything else in this video is about how well a given regimen recreates those two separate jobs. Now here's the debate. You've probably heard people argue that simpler is always better. Others swear intensive regimens are the only real way to control blood sugar, and a third camp insists it depends entirely on the individual. All three are partly right, and the data actually gives a clear way to sort it out. The simple camp is talking about long-acting insulin alone, 1 or 2 injections a day of a basal insulin, time to cover fasting blood sugar without touching mealtime spikes. This works when a person's body still produces a meaningful amount of its own insulin at mealtimes, commonly the case in milder type 2 diabetes. The test is straightforward. If blood sugar rises no more than about 10 milligrams per deciliter after meals despite maximum use of insulin-sensitizing medication, no mealtime insulin is needed at all. The threshold that tips the decision is that same 10 milligrams per deciliter mark, consistently below it. Simple wins. The intensive camp is talking about basal-bolus therapy, long-acting insulin for the fasting state, plus rapid-acting insulin before every meal, mimicking both halves of normal pancreatic function. This is standard for essentially all type 1 diabetics because their beta cells produce little or no insulin of their own, meaning nothing is covering mealtime glucose unless it's injected. It's also common for type 2 diabetics whose beta cell function has declined significantly over time, which happens often enough that many long-standing type 2 cases functionally resemble type 1. The mechanism here is simple. If the body can't release its own mealtime bolus, an external one has to replace it, or blood sugar rises unchecked after every meal. So how do you know which situation applies? For concrete signals. First, track whether blood sugar rises more than 10 milligrams per deciliter after meals even with maximum medication. If yes, that's a vote for intensive. Second, check fasting blood sugar against bedtime blood sugar over multiple nights. A consistent overnight rise points toward needing basal insulin at minimum. Third, look at how long the person has had diabetes and whether beta cell function has been formally tested, since declining insulin production over time shifts almost everyone toward intensive therapy eventually. Fourth, consider whether blood sugar swings are large and unpredictable day-to-day. Tight, stable patterns can sometimes be managed with lower total insulin even on an intensive schedule, while erratic patterns almost always need mealtime coverage. Here's the one exception worth knowing. Even within intensive regimens, some patients only need rapid-acting insulin before certain meals rather than all three, because glucose profiles occasionally show that only one meal, often the one associated with lower activity or a specific eating pattern, causes a real spike. So intensive doesn't always mean 5 injections a day. It means covering whichever specific gaps the data reveals. That bridges us to the mechanism behind why timing matters just as much as which regimen you're on. Regular insulin needs roughly 40 to 45 minutes to start working, so it has to be injected well before food arrives. Rapid-acting analogs like the newer insulin types start working in about 15 minutes, which makes them far more practical when meal timing is unpredictable, restaurants, travel, anyone whose schedule shifts day to day. The trade-off is that these faster insulins have a sharper, less predictable peak, making them slightly harder to match precisely to how fast carbohydrate is digested. Neither is universally superior. The choice depends on how predictable a person's eating schedule is. One more mechanism explains why fasting blood sugar control specifically depends on the bedtime dose, not the morning dose, a distinction that trips up a lot of people managing their own data. The overnight basal insulin is what determines where blood sugar sits when you wake up, so if fasting numbers run high morning after morning, adjusting the bedtime dose is the correct move, not the morning dose. Many people instinctively do the opposite, and it rarely fixes the problem. If you want to actually understand where your own numbers fall on any of this, the next video breaks down exactly how blood sugar profiles are read and adjusted week to week. Hit subscribe so you don't miss it. To bring it all together, insulin regimens exist on a spectrum, not a binary choice. The determining factor isn't preference, it's how much insulin the body still makes on its own, verified through actual blood sugar data over multiple days and reviewed by a physician who can safely calculate the numbers involved. The biological question is simple. The only insulin your body doesn't produce is the insulin you have to replace, and everything about simple versus intensive therapy comes down to measuring exactly how much that is. If you're serious about actually understanding how your body regulates blood sugar and want the full picture instead of guesswork, hit subscribe so you never miss the next breakdown.